The instruction on the medication label typically reads, "Take 1 tablet daily." 4 words that say nothing about when, nothing about what to take it with, nothing about what to avoid in the hours around taking it, and nothing about what to do on the day you forget. For most adults over 60, this is the entirety of the timing guidance they receive, and it leaves them making timing decisions by default, taking the medication at whatever time fits their existing morning routine, consuming it with whatever they happen to be drinking, and managing missed doses by instinct, rather than by the specific guidance that applies to their particular medication. Timing matters more for blood pressure medications than for most drug classes, because blood pressure itself is not static. It follows the circadian rhythm we have discussed across multiple videos on this channel, falling during sleep, surging in the first 2 hours after waking, peaking in the late morning, declining through the afternoon, and rising again mildly in the early evening. The medication that is present in the blood at adequate concentration during the morning surge, when arterial events are most likely to occur, is providing protection when it matters most. The medication that has already been metabolized and cleared by the morning surge is providing protection during a period of lower risk, while missing the window of highest risk. Before anything else, what I share here is educational information only. It is not medical advice. Do not change the timing of any blood pressure medication without specifically discussing it with your prescribing physician or pharmacist, because the appropriate timing varies by medication class and by individual clinical factors. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. Subscribe to this channel now, because every week I bring you specific, grounded information about what your body needs after 60. The 5th mistake is taking diuretic medications too late in the day, and it is placed 5th because it is the most simply correctable of the 5, and the one whose correction produces the most immediate quality of life benefit. Diuretics, specifically the thiazide diuretics including hydrochlorothiazide and chlortalidone, and the loop diuretics including furosemide and bumetanide, commonly used in heart failure, reduce blood pressure by increasing urinary sodium and water excretion. They continue to produce diuresis for a period after each dose that varies by the specific medication. Hydrochlorothiazide produces diuresis for approximately 6 to 12 hours after each dose, chlortalidone for 24 to 72 hours, and furosemide for approximately 6 hours. An adult who takes a diuretic at 6 in the evening is experiencing its peak diuretic effect between approximately 6 and 10 in the evening and into the night. The increased urinary frequency during this period means multiple nocturnal trips to the bathroom, often 2 to 4 additional bathroom visits between midnight and morning. In adults over 60 whose balance and spatial orientation during sleep-to-waking transitions is impaired, and whose bedroom environment in the dark carries fall hazards, each nocturnal bathroom trip is a fall opportunity. The Nurses' Health Study and multiple geriatric fall studies have specifically identified nocturnal diuretic-related bathroom trips as a significant contributor to the fall rate in adults over 65 taking diuretic medications, with the risk specifically concentrated in the first 2 hours after rising from sleep for a bathroom visit. The correction is straightforward. Take diuretics in the morning with the first meal of the day. For most diuretics, morning dosing provides equivalent blood pressure control to evening dosing, while concentrating the diuretic effect in the daytime hours when the person is mobile, alert, and in a lower fall risk state. We discussed this specifically in our Nocturia video on this channel, in the context of the relationship between diuretic timing and nighttime urination frequency. The exception, adults whose primary indication for the diuretic is fluid retention from heart failure, who have been specifically advised to take it at a particular time for cardiac rather than blood pressure reasons, should discuss any timing change with their cardiologist before adjusting. Type in the comments right now whether you take a diuretic and whether you have ever specifically asked your doctor what time of day is most appropriate for your specific diuretic medication, because the frequency of unreviewed diuretic timing in those comments tells me something important about how systematically this question is being addressed in standard prescribing consultations. The 4th mistake is consuming grapefruit or grapefruit-containing products around the time of certain blood pressure medications, and we covered the mechanism in specific detail in our amlodipine patient education video. To briefly recap for the broader context, grapefruit contains furanocoumarins including 6,7-dihydroxybergamotin that irreversibly inhibit the CYP3A4 enzyme in the intestinal wall. This enzyme is responsible for the first-pass metabolism of many medications, including amlodipine, felodipine, and several other dihydropyridine calcium channel blockers. When CYP3A4 is inhibited by grapefruit, a larger proportion of the ingested dose reaches the systemic circulation, producing blood concentrations substantially higher than intended and amplifying the medication's blood pressure lowering effect to a degree that can produce dangerous hypotension. The timing aspect that many patients do not know is critical. The CYP3A4 inhibition from grapefruit is irreversible for the affected enzyme molecules. The effect persists for 24 to 72 hours after grapefruit consumption, rather than clearing as soon as the grapefruit has been digested. This means that drinking grapefruit juice at breakfast and taking amlodipine at dinner is not a strategy that avoids the interaction. A single glass of grapefruit juice can produce clinically significant drug level elevation for 1 to 3 days. For adults taking any calcium channel blocker, specifically amlodipine, felodipine, nifedipine, and nisoldipine, grapefruit avoidance should be complete and ongoing rather than intermittent or timed. Regular oranges, mandarins, lemons, and limes do not contain furan coumarins in clinically significant quantities and are safe alongside these medications. And share this video right now with one person in your life over 60 who takes amlodipine or felodipine and who regularly drinks grapefruit juice for its supposed health benefits without knowing that the same biological property making grapefruit potentially beneficial, its CYP3A4 inhibitory activity, is specifically what makes it dangerous with this medication class. And if you are not yet subscribed to this channel, tap that button now and ring the bell. The third mistake is the timing relationship between caffeine consumption and beta blocker or alpha blocker blood pressure medications, and it is more nuanced than a simple avoidance recommendation. Beta blockers, including atenolol, bisoprolol, carvedilol, and metoprolol, reduce blood pressure and heart rate by blocking beta-adrenergic receptors, reducing the sympathetic nervous system's effect on the heart and vasculature. Caffeine stimulates the sympathetic nervous system and produces blood pressure and heart rate elevation through the same adrenergic pathway that beta blockers suppress. The practical consequence is that high caffeine consumption partially antagonizes the anti-hypertensive effect of beta blockers. The caffeine is activating the receptors the medication is trying to block. This does not mean that patients on beta blockers must eliminate caffeine entirely. Moderate caffeine consumption, 2 to 3 cups of coffee daily, is generally tolerated alongside beta blockers without clinically significant reduction in antihypertensive effect. The timing issue is specifically relevant for very high caffeine consumers or for adults who concentrate their caffeine intake in the same narrow window as their medication, producing a simultaneous peak of caffeine sympathetic stimulation and medication-suppressed receptor response that may be more clinically significant than the same total caffeine intake spread across the day. The practical guidance: take beta blocker medications consistently at the same time, regardless of coffee intake, but consider spacing the first coffee by 30 to 60 minutes from the medication dose rather than consuming both simultaneously. And if blood pressure control has been unsatisfactory despite medication adherence, specifically mention caffeine intake quantity and timing to the prescribing physician as a potentially relevant variable. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell. The fourth mistake is the missed dose double up, and the appropriate management depends specifically on which medication was missed and by how much time. For most blood pressure medications, the general principle is, if you remember a missed dose within 6 to 8 hours of the scheduled time, take it as soon as you remember and continue the normal schedule. If it is more than 6 to 8 hours since the scheduled time, and the next dose is less than 8 hours away, skip the missed dose and take the next scheduled dose at the normal time. Never double the dose to make up for a missed one. The reason doubling up is specifically dangerous is that the cardiovascular effects of a double dose are roughly additive, rather than simply equivalent to a normal dose taken late. An adult who takes 2 amlodipine tablets produces a vasodilation substantially exceeding the therapeutic target, potentially producing a significant blood pressure drop, reflex tachycardia, and the orthostatic hypotension risk whose severe form can cause falls or syncope. For beta blockers, doubling the dose can produce excessive bradycardia. For diuretics, doubling can produce acute dehydration. The specific caveat for medications with very long half-lives Amlodipine has a half-life of 35 to 50 hours, meaning a missed dose produces relatively little change in steady-state blood concentration, because the previous day's dose is still largely present in the circulation. Missing a single dose of amlodipine is less clinically significant than missing a dose of a shorter-acting antihypertensive, and the instinct to double up is specifically less warranted. Any adult who regularly misses doses because the timing is inconvenient or because the medication fits poorly into their daily routine should discuss this with their prescribing physician or pharmacist, who can often identify a formulation, timing, or reminder system that improves adherence more effectively than continued inconsistency. The first mistake, placed first because it reflects the most significant and most actively debated evidence in blood pressure medication management, is the question of morning versus bedtime dosing for blood pressure medications generally. The concept that drove interest in bedtime dosing is chronotherapeutics, the idea that blood pressure medications should be timed to provide their peak effect during the morning danger zone, the 2 to 4 hours after waking when blood pressure surges, and cardiovascular events peak. If a medication is taken at bedtime and has a half-life of 12 to 24 hours, its concentration may be adequate through the morning surge of the following day. If taken in the morning, the concentration may have fallen significantly by the following morning, providing less protection during the highest risk window. The Hygia chronotherapy trial, published in the European Heart Journal in 2020, produced dramatic findings. In a study of nearly 20,000 hypertensive adults followed for a median of 6 years, bedtime dosing of antihypertensive medications was associated with a significantly lower cardiovascular event rate, lower stroke rate, lower heart failure rate, and lower all-cause mortality compared to morning dosing. These findings attracted enormous attention and prompted many clinicians and patients to shift toward bedtime dosing. However, the TIME trial, a randomized controlled trial published in The Lancet in 2022, specifically designed as a rigorous investigation of this question, enrolled 21,000 adults with hypertension in the United Kingdom and randomized them to morning or evening dosing of their existing antihypertensive medications. The TIME trial found no significant difference in cardiovascular outcomes, heart attack rate, or stroke rate between the two dosing times. This directly contradicted the Hygia findings. The methodological concerns about the Hygia trial, including questions about the data integrity and the remarkably large effect sizes compared to other trials, have led most major cardiovascular guidelines to maintain a neutral position on dosing time pending further evidence. The current evidence does not support a blanket recommendation to switch all antihypertensive medications to bedtime dosing. What does have clear evidence is the morning blood pressure reading as a guide to medication timing. An adult whose home blood pressure readings show inadequate control specifically in the first 15 minutes after waking, as we have discussed extensively in our blood pressure routine and systolic blood pressure videos, may benefit from discussing medication timing adjustments specifically with their physician. If the morning surge is not being adequately covered by the current timing, adjusting the timing or the formulation to provide better morning coverage is a legitimate clinical conversation. The 5 questions every senior should ask at their next appointment or refill: what time of day is most appropriate for each of my blood pressure medications, and why? Are any of my medications affected by grapefruit or other food interactions? What should I do if I miss a dose of each medication? Does my morning home blood pressure reading suggest that my current timing is providing adequate protection during the morning surge? And are there any of my other medications, including over-the-counter ones, that may be interacting with or opposing the effects of my blood pressure treatment? 4 things to carry away. Diuretics should be taken in the morning with the first meal of the day to concentrate their diuretic effect in daytime hours and prevent nocturnal falls from overnight bathroom trips. Grapefruit avoidance for calcium channel blocker users must be complete and ongoing rather than timed, because the CYP3A4 inhibition persists for 24 to 72 hours after a single serving. Missed doses should be managed according to the time elapsed, with a general principle of skipping rather than doubling if the next scheduled dose is within 8 hours. The morning versus bedtime dosing question is genuinely unresolved, with the Hygia and TIME trials producing contradictory findings, and the most appropriate approach is a conversation with the prescribing physician about the specific timing that best addresses the patient's individual blood pressure pattern. Share this video with one adult over 60 in your life who takes blood pressure medication and who has never had a specific conversation with their prescribing physician about the timing of each medication in relation to their home blood pressure pattern, because the timing conversation may produce more benefit per clinic minute than any other blood pressure management discussion available. And subscribe to this channel because every week I come here with one purpose: to give you the specific information that makes the medications you are already taking work as effectively as the evidence supports. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.